Kathryn Mannix has spent her entire medical career working with people who have incurable, advanced illnesses, but generally in hospital, starting in cancer care and changing career to become a pioneer of the new discipline of palliative medicine. She
Oh,
has worked
exactly. Thank
in
you for
teams in
inviting me.
hospices, hospitals, and inpatients' own homes to deliver palliative care, optimizing quality of life even as death is approaching, and even at times when death isn't approaching and you're just making people comfortable. So, having qualified as a cognitive behavioural therapist in '93, she started the UK's first CBT clinic exclusively for palliative care patients and devised the CBT First Aid training to enable palliative care colleagues to add new skills to their repertoire for helping patients. Now, Dr. Mannix, because she is a doctor, has worked with many thousands of dying people and has found their ability to deal with illness and death both fascinating and inspirational. She believes that better public awareness about what happens as we die would actually reduce the fear and enable people to discuss their hopes and plans with the people who actually matter to them. She's the author of Listen, How to Find the Words for Tender Conversations, and we're talking about her best-selling book, With the End in Mind. So, I've got to ask, why are people so afraid of talking about this, talking about dying and death?
Fascinating, isn't it? I think it's layered. I think there are probably different things in different places and for different people. So partly it's cultural, and there are some places in the world where it's rude or it's in some way not respectful to have that conversation. And I have colleagues who work in palliative care in places where actually they have to be very, very careful to get permission to transgress in order to be able to have that conversation in a respectful way. But I think here in the UK, it's a mixture of things. It's not a pleasant subject, is it? It's a thing that we try not to think about because it makes us sad. And if it makes us sad, then maybe it's going to make the person that I try to talk to about it sad. And that feels like maybe that's not a kind thing to do. But it turns out that not talking about it also makes us sad. It makes us sad at a different time. So people reach the end of their lives wishing they knew more, or people reach bereavement wishing they'd said the really important things in their hearts, and they haven't said them in case they caused distress. And now they carry the regret of not having said. So it turns out, if you offer to talk about dying, people don't back away. People actually lean in and go, oh, yeah, do you know, I've always wondered about that. So we describe it as a taboo. But I'm not convinced actually that it is a taboo. I think we're just all a little bit too polite.
Oh God, that's really depressing, isn't it? We're too polite to talk about such an important part of your everyone's life that's inevitable. But you know, it's you talk about these incredible case studies. I guess they are incredible because just you're right. It's such a privilege to be able to hear about someone's last moments, I guess. So what I found really interesting is your ability to kind of understand how to approach each one. So, how do you know when to give reassurance or just listen?
Oh, I guess it's a little bit like tightrope walking. And I suspect that the guy who's walking the tightrope or the gal who's walking the tightrope doesn't think about walking the tightrope very much, because once they start to think about it, they'll overthink it. And I wonder whether we overthink a little bit in these conversations too, instead of just trusting ourselves. We've been able to speak in words that describe what's going on inside us since we were about 3 years old. And we don't stop and think about it. We don't try and plan the words. We just open our mouths and the thing we meant to say, more or less, comes out.
Yeah.
So maybe the thing that we could do thinking about is not overthinking, oh, okay, so I'm going to go and talk to my mum about what funeral arrangements she would like. So I'm going to start by saying, okay, Mum, I really hope this isn't going to upset you, and I promise it won't take very long. Or, okay, so I have to start like that. And then the next thing I need to say, I've got a kind of list in my head. Now I'm thinking about the tightrope, aren't I? I'm thinking about the conversation instead of going in and talking to my mum like she's my mum and I'm her daughter and saying, Mum, there's this thing, you know, it keeps coming round in my head and I'm worrying about it a bit. Can we talk about it? Being one's mother, almost certainly that person will say, oh, I don't like the idea that you're worrying about something. What can I do to help? And then you say, well, actually, it is a thing that you might particularly want to talk about, but I think it could help me a lot if I knew what plans you wanted for your funeral, or if you got really sick and couldn't tell the doctors what you wanted and they asked me what you wanted, crikey, I wouldn't know.
Yeah.
You know, could we talk about that sometime? And I think the other thing there is it's an invitation into a conversation, isn't it? Rather than just going in and thinking, right, I've got to get in, I've got to get to the bottom of it, I've got to sort it all out, and I've got to get out without causing anybody to be distressed, because conversations are collaborative things, and what happens. So, and I guess really a lot of that comes in my second book, Listen, which I'd never intended to write, but came from the feedback from the first book, which was, okay, you've convinced us we need to talk about this stuff. But how on earth do you start those conversations? So the second book isn't really a deathly book, but it is a book about conversations that we feel a bit daunted about getting into, including these ones.
Yeah, and this is a big one, isn't it? In terms of, I think people are probably the most uncomfortable having this conversation about, I think, more than any other subject. So what do you think is the impact of like denial when it comes to death?
I think denial is a really interesting thing to talk about because it's two-sided. If you can really believe that the thing that's upsetting everybody else isn't true, if you can really deeply believe that, hold that belief in your mind at all times, then because it's not true, you won't feel the distress of it. And there's a story in the book of a young woman who never believed that she was so sick that she would die.
Where it came from. This is
And
why I
she
was
was
wondering.
remarkable. So denial, we talk about it as though it's a bad thing, but actually if it really, really works, it can be a very protective thing. The difficulty is that everybody around the sick person who's not doing denial now is stymied because they don't know how to talk in front of that person about the things that matter most to them. The difficulty we have, that most people have, and that this dear woman didn't have, because I'd known her a long time. I'd known her when I was a cancer doctor when she first started her treatment. And then I looked after her again when I was a palliative care doctor towards the very end of her life. And her denial never wavered. But a lot of people, towards the end of their lives, the wheels start to come off. You know, it gets increasingly difficult to pretend that everything's okay when you haven't got the energy to get out of bed. You've lost your appetite. Maybe you're uncomfortable, or you don't breathe as easily as you used to, or whatever. And gradually the reality dawns and breaks through the denial and causes anxiety, which then is difficult to deal with because there isn't enough time left to process it. Whereas people who go through the process of, and you'll understand this, getting a diagnosis of an illness that's serious and might be going to progress, that's not good news. There's no way you're going to make that into good news. And the person goes into a period of emotional upping and downing of, well, what if this and what if that? And oh my God, if that happens, what about this and what about that? And gradually they get the information they need to think, okay, well, what if that? Well, I need a plan in case that happens, but that isn't usually what happens to people like me with this illness.
Right.
So the more they have information, the more their anxiety level comes back down to, okay, my life is going to be different from what I was expecting, but I know what to expect now and I can make a different plan to deal with what's unfolding in my life instead. So that anxiety phase doesn't persist for an indefinite amount of time. It gradually is replaced by a new plan. But if that is deferred until very close to dying, then that's quite difficult for people.
Yeah, definitely. And just reading that story, I remember I was just like, Wow. I was just like, wow, but this is an interesting way of dealing with it. But then I also remember the story of the father who died of, I think, a heart disease, and his sons saying that they didn't want to talk about his death when he was alive, which was really interesting because I was like, so how do we get more people to be more open about speaking about death, especially if it's not their own, but someone
Yeah.
else's?
That family, the story of the elderly dad who was brought into hospital
Mm,
by ambulance, that was the family that tipped me over the edge into campaigning, and
mm,
the book was a result of that, because it was just patently obvious that this man was in his late 70s. He had so many different things wrong with him.
mm.
It was easier to summarize what was still working okay,
Oh
really.
God.
And his sons were unable to deal with it. And yet their mother said to them, your dad and I have talked about this a lot. I always hoped that I would die before him, and he hoped that he would die before me.
Mm,
But we both knew one of us would have to die first.
mhm.
And now is not the time for, heroic, intrusive treatment that isn't going to help him. What we have to do now is help him to be
Yeah.
peaceful. So what's interesting is that although the sons couldn't talk about it because he was their dad, even though the sons were probably in their 70s,
Yeah. Oh.
he was still their dad.
Wow.
They were like little boys because this was their precious dad.
Yeah.
But their mum and dad, who were aging together, were also talking about the consequences of
Mm,
aging together, and they were wondering about how they would each deal with it when the time came that it was clear that one or other of them was dying. So I wonder what would have happened if the sons had allowed dad to talk about it. And of course, they both confessed
mm,
then in the resuscitation room in the hospital that dad had tried to have a conversation with
mm,
each of them, and each of them had closed it down because they felt uncomfortable.
mm,
So, one of the things that I see happening, and you may have explored this a bit, I don't know, is that there are ways that people can talk about dying that aren't with their families. And Death Cafe is one of those movements where people can go and meet complete strangers, people who don't have an emotional investment in what their end of life will be like. And quite often, I've been to a lot of death cafes now,
wow.
there are people who talk about, I want to practice saying what I need to say to my kids, or I want to practice what I need to say to my parents about my illness because they find it so difficult to listen to. Or this is what happened when I told my family. Oh, that's really interesting. Okay, that might be a way that I could approach it. So death cafes talk about anything and everything. So your listeners might not know about death cafes, but it's an international movement. They've got a website, and they've got a logo, which is fantastic, which is a really gorgeous china cup and saucer with a skull
Love
on it.
it. Mm,
And it's just a place where the rules are, it has to be free to attend.
mm.
Anybody can run one. There has to be excellent cake. So, I'm already a supporter. And that you talk about what you want to talk about. So I've heard people talking about their beliefs about what happens after you die. Is there an afterlife or not? If there
Mm,
is, or, what is it about? I've heard people talking about funeral plans and talking about how to talk to their families about their illness, or whether they would, particularly after COVID, quite a lot of people
mm,
discussing, would they have wanted to be in an intensive care unit, or would they have preferred to take their chances and stay at home and not be separated from their families, because people made those sorts of choices, didn't they,
mm,
during COVID? So I think maybe these are conversations that are a little bit easier to have with people who you're not emotionally entangled with, which brings me all the way back to your question, which was, how do you know what to say? And I think for me, there are two things. I am not at all perturbed about talking about dying.
mm,
I have seen ordinary dying up close and personal thousands and thousands of times. And the more I see it, the less afraid I am for myself and for my family. So if somebody wants to talk about it, then I will talk about it. So I'm not trying to manage the conversation so we don't go there.
mm,
And I think that makes me more relaxed. And sometimes we we'll go there. And usually we won't. But if we do, that's okay.
Yeah.
So I'm not getting het up as the conversation drifts deathwards. And then the other thing is that I'm this person's doctor. I'm not their daughter. I'm not their wife. I'm not their best friend. So they can say things to me where they don't have to worry about whether it's going to make me sad because my life is entwined with theirs. So maybe that's given me lots of different kind of windows to look through into so many, hundreds and thousands of families. And it's an incredible privilege, really, isn't it?
Yeah.
And it's meant that when I have been beside my own dear people at the end of their lives, I'm forewarned. I know what to expect. I understand what the process is going to be. But it's still harder to talk about it with the people that I love than it is with the people who I serve as their doctor.
Yeah, I can totally imagine that. And when you described some of the more close family ties and friends and stuff, it was harrowing to think about it, especially young child and things like that. It's really sad. But do you find there's a difference for you, like when you're dealing with quick, painful deaths and long drawn out ones?
Okay, that's a really important question. So, most of us will die of something that we've had for a while. So most of us will die of some kind of long-term condition. And because we're living longer and longer, many of us will die either of or at least with dementia. And that became the commonest cause of death in women over the age of, I think, 80, about 5 years ago.
Wow.
And so still is. So although the chances of getting dementia are getting less because preventative health care, so good heart health and good lung health and things like that are preventing us from having the vascular diseases in our brains that can make dementia happen more quickly. So fewer of us are getting dementia, but more of us are living long enough to get it. So the statistics are going in that direction. Whereas very few of us will suddenly have a heart attack, get a pain in our chest, drop to the ground and be dead. And for those of us who do that, that will almost never be a surprise. It will almost always be somebody who's been known to have heart disease for some period of time.
Right.
So the event itself may be sudden, but the heart disease itself was already known about. So those are the circumstances in which we need to have those conversations ahead of time with people, aren't they? And the fancy term for that is advanced care planning. It's just planning ahead. It's what you do when you're going on holiday. You make a list. You make sure you've packed everything. So for people who've got heart disease, to start off with, they probably need to get to the hospital really quickly and get sorted out by a cardiac care unit or an intensive care unit. So whatever's happening to their heart causes the least possible damage. And we've got so many treatments we can give for a person in the middle of a heart attack now that just didn't exist when I first qualified as a doctor. Progress in medicine is fantastic. So early on, a person with heart disease who gets pain in their chest should get to hospital as quickly as possible. But after 40 or 50 years of heart disease, you've gradually done more and more damage to that heart. It's doing its best, but it's struggling now, like that man on that stretcher in the story. And now all those fancy things that we can do in a cardiac care unit and an intensive care unit are going to be of little or no benefit. So the advanced care planning conversation is to help people to know that actually early on in my illness, do everything. If there's any treatment available that might benefit me, even if it hurts, even if it's a risk, just do that because I want to stay alive more than anything else. Whereas somebody else might say, well, hang on, what's the risk that my body would be alive, but my brain wouldn't be alive after something like that? Okay, I don't want you to do all of that invasive stuff if there's a risk that I'll be in a long-term coma with no quality of life at all. So now I need people to know I'll accept treatment up to this point, but after that, I refuse it. And I can make a decision in advance to refuse that treatment. And as we get closer and closer towards the natural end of life anyway, either because our lungs or our kidneys or our heart or whatever are getting more and more damaged by the illness we've got, or just because we're in our 80s and 90s and we're getting towards the end of lifespan, generally most of us consider that we'd like less messing on in terms of medical interventions and more companionship and peace of mind and being able to be comfortable. And it's that balance between adding days to somebody's life or adding life to the days that are left at the end of their life. So it's unusual for people to die suddenly and in pain. Heart attacks generally do give people pain in their chest. If it's so severe that their heart is going to not be able to work, they will usually drop their blood pressure and pass out and become unconscious very, very quickly. So probably won't be in pain for a great deal of time.
Wow.
But most of us will have an illness that includes a kind of preparatory phase towards the end of life. And I have to say to you that if I don't get a deathbed, I'm going to feel really, really robbed. After all this work that I've done to get that kind of normalised and accepted, and let's get people understanding that pattern of gradually losing consciousness, coming and going for a while until the person's deeply unconscious, and then the weird breathing that unconscious people do, which if you haven't seen it before, you really might think the person was having a horrible time. So that has to not be a secret anymore. That unconscious breathing is very noisy and very weird, and it tells us that the person is so unconscious that they can't feel their throats. So they're not having a horrible time, but we listen to it and we think, oh my God, that sounds terrible. That sounds like really hard work. Or I can hear a bubbling noise. Is she drowning? Whereas actually probably what's happening is there's a little kind of teaspoonful of phlegm at the back of the person's throat. And the reason it's bubbling is because it's not interfering with their breathing. The breath's coming in and out through it quite easily, but it's making that funny bubbling noise as it goes through it. That people are usually not conscious by the time they're reaching their very last breaths. They're not awake and terrified and, clutching to the edge of the bed with white knuckles. They're deeply unconscious, deeply relaxed. Breathing is slowing down and very gently stops. And if the people who love them around the bed understand all of that, then they won't be traumatized by it either. So, yes, I wouldn't want to have a sudden, unexpected death, even though everybody says, "Oh, I hope I just drop down dead." Maybe that's a lot less fuss for the dying person, but the lack of opportunity to say goodbye for the people who will be bereaved is often a very heavy burden for them.
That's very true, actually. I think we often forget that, isn't it? Because we see it from one side. And actually, this reminded me of something because you talked about this, which was like, I guess maybe in the past, sometime in history, there used to be a much more kind of approachable way of dealing with death, maybe because it was so widespread. But why have we forgotten the art of dying?
Yeah, it fascinates me. I talk a lot about my nana about this. So my nana, my mum's mum, was born in 1900 in a not very well-to-do area of Liverpool. So life expectancy for girls in 1900 in Britain was 46.
Wow.
Okay, so average life expectancy, half of women born in 1900, half of female babies born in 1900 would die before their 46th birthday, and the other half would die, kind of a curve that goes up and then down the other side. And she understood dying and death because she was a teenager and in her 20s in the 19-teens and the 1920s. It's handy when your nana's birthday is 1900 because she's always the same age as the year. But she learnt about it from her mum and from her aunties, looking after people who were so sick that they were dying. Hospital had nothing to offer. We didn't have intensive care units. They probably couldn't afford hospital anyway,
Yeah.
frankly. So what happened when people were dying was that friends and neighbours and family just helped to support them while they were doing their dying. And they would know from watching what was happening to the person when it was time to send for, well, where they lived, it would have been a vicar or a rabbi or a Catholic priest in the area that they lived. But in other parts of the world, it would be whoever would be the kind of faith leader that would begin the really important ceremonies and prayers that are consoling to the people who have those beliefs. And it's part of the ritual, isn't it, that it has to happen properly. The right verses of the Quran need to be read in some places, or the bed needs to be facing in the right direction, and the person lying on the bed needs to be facing in the right direction in other cultures. So it's really important that the family would recognise and know when it was time to do those parts of the ritual.
True.
And I guess that my nana thought that in the fullness of time she would teach her daughters and her nieces the same things that she'd been taught by her mum and her aunties. But what happened was that the 20th century got really good at medicine. And it's fantastic, really. Her husband died of a ruptured appendix. He had appendicitis in his 30s.
Oh
She
my
was a
God.
widow. In her mid-30s, she was a widow. One of her children, her oldest child, died of an infectious disease we routinely immunise children against now. So she was widowed with 3 children and a baby on the way.
Oh my God.
And, that's the mid-1930s. She's in her mid-30s, and that's women's experience of dying and death for the last, hundreds of years. She didn't die at 46 or thereabouts, and in her 90s said to me that she wanted to talk to me about dying because she was a bit concerned. I thought, okay, this is an interesting conversation. So this is the mid-1990s, and I'm a consultant in palliative medicine. So that's why she's chosen me out of her, dozen grandchildren to talk to about it. And she said, I'm not worried about doing the dying. And I know that that's ordinary and okay, and, seen it lots of times, not going to be a bother. What worries me, she said, is I don't think that your mum and her sister and brothers have ever seen a person die.
Oh, wow.
I just thought, it's like a light bulb moment. Here's this woman in her 90s who by her 30s was familiar enough with dying that she absolutely understood it, and she's carrying that with her like a little light inside her. She knows what to expect and she's not frightened about it. But she's concerned that her children, the next generation, have completely lost the wisdom, and she hasn't been able to give it to them because dying people didn't stay at home to die. They went into hospital in case they could be saved from dying. And of course, lots of people were saved from dying that time around.
Yeah.
But we didn't cure death yet, as far as I've noticed. And so, the death rate is still 100%. It's just we've forgotten what it looks like, and we've forgotten how to talk about it. I suspect her generation didn't talk about it much, but they saw it enough that they didn't need to talk about it. Everybody knew what everybody knew. And so we need to talk about it, because when we don't know something, our minds don't know that we don't know.
Yeah.
Right? Our minds think, oh yeah, I know about that because I saw it on EastEnders. And oh yeah, that film Stepmom. And so we go through all these kind of cultural references that tell us what dying will look like. And we think they're true. And the other thing that tells us what we think dying will look like is newspapers, media stories about grim, gruesome,
Really
terrible,
grim.
awful deaths. Okay, so got 2 things to say about that. The first thing is that we mustn't pretend that there aren't sometimes grim, gruesome, dreadful deaths. Just as sometimes there are births that go horribly wrong, mothers die, babies are damaged, babies die. That's not what we expect birth to be. And when that happens, it's an exception. It's really rare, but it can happen.
Yeah.
And there can be uncomfortable dying too. The difficulty is that the uncomfortable dying and the damaged baby at birth, those are the things that cause complaints, letters to newspapers, letters to members of parliament. They get into the newspapers. And if you stop and think about what you know about air travel, if you only knew about air travel what you read in newspapers, you absolutely would never get on a plane.
Yeah, true.
Yeah, because all of the references are about disasters.
It's very true. Yeah. Crashes. Yeah.
And it's true that those things did happen, but what they don't do is give you the context of. I did look this up once. I think it's something like 100,000 or 200,000 flights every 24 hours. 6 million people, anyway, getting moved around the world every day in planes. And, almost always a plane leaves one airport, gets to another airport. It's got the same number of people on it that left the first airport. Nobody fell out or died on the way. So we need to get back to thinking about if there are exceptional, uncomfortable, difficult deaths, we need to take that very, very seriously. We need to think about whether there needed to have been better preparation, whether people needed to be able to step in with medicines that would have relieved some of the symptoms more quickly or whatever. So, each of those is an occasion to think what could be done better so that people didn't have that experience. But we also have to remember that it's a truly exceptional experience, and that the earlier we talk about the end of life, particularly during an illness that's likely to end somebody's life, the earlier we can start to get the plans in place for whatever the symptoms might be that particular illness causes. So I work up in the northeast of England, and we used to have a lot of coal mines up there. We used to have a lot of iron and steel works up there. So we had a lot of elderly men whose lungs were full of coal dust or smoke from working in foundries. And so they generally had lung disease and associated heart disease. And so we needed to have plans for them for what would happen if they got really breathless or if they got pain in their chest from lots of, you've got a bad cough and you cough and cough and cough, and eventually your ribs and your diaphragm get sore from all the coughing. So what are the plans for these guys for pains in their chest and breathlessness? And they're different plans from the plans that we would make for this lady who's got heart disease or this person who's got young onset dementia. So we need a plan that we've talked about in a realistic way, that we want to help you to live as well as you can live despite the illness that you've got. But we're not silly. There may well be days that are more difficult than others. What's the plan going to be for those days? So you don't wake up in a panic thinking, oh, I can't breathe and I don't know what to do about it. You wake up thinking, well, I'm a bit breathless this morning. I'll get that list out because I know I've got 3 steps that I can take at home. And the 4th step is I've got to phone my GP or whatever. But I'm not left feeling helpless and not knowing what to do.
Yeah, absolutely. It's good to have those kind of the information, I think, as you say. Otherwise it is a bit scary. I think the prospect of it is just like the fact that we don't know anything about it. And as you say, we just have pop culture references to sort of go based upon those kind of things and the news and things like that. And it's really interesting. But then we know there are difficult deaths, but are there some deaths more difficult to deal with than others?
Yes, there are. And I think what's really interesting about those is that there is a difference between pain and suffering.
True.
And we've all had days where we've had pains, terrible headache, horrible period pains, awful arthritis, whatever it is. And it's annoyed us and it's interfered with our pleasure in that day, and maybe we've been restricted in what we could do, and maybe we've taken some painkillers, or maybe we've just kind of toughed it out. But we wouldn't describe that usually as suffering. Whereas suffering is something about what I'm experiencing is intolerable to me, that it's undoing who I want to be and how I want to be. And it might not be a very strong symptom. It might not be a pain that's stronger than a couple of paracetamols might take away. But it's a pain that reminds me that I have an illness that is taking my life away, that is taking me away from everything that matters to me, that I haven't finished my living yet, that I have unfinished business, that I have unresolved relationships. And the thing that strikes me over and over when I see people who are suffering towards the end of their life, rather than intermittently having symptoms towards the end of their life, is that it is a deeply emotional thing that's going on for them. It's not really about the symptoms, it's about the meaning of the symptoms, and it's about their grief for the loss of themselves, or the grief for the loss of the people and the life that means so much to them. So that's, I think, what made me so interested in cognitive behaviour therapy, because once upon a time I might have thought that surely everybody feels like that as they get towards the end of their life. And yet when you work in palliative care, what you find is that most people are not highly anxious and hugely depressed. Most people get up in the morning and have an average day with some good bits in it and some, not so good bits in it, like the rest of us. And so it's not normal to be depressed. It's not normal to be anxious. It's not normal to be overwhelmed with grief. And if that's not normal, it means we can learn from the people who are making the emotional adjustment that allows them still to enjoy their days and feel contented, and work out what it is that they are doing. How are they processing the experience of reaching towards the end of their lives that they're having? And what is it that's different about people who, at the same life stage, are suffering an overwhelming sense of the unbearability of the situation they find themselves in? And very often it's actually not about the symptoms or even about the farewells, it's about the lack of control of it. Because we spend our lives thinking that we have control, which is itself a form of denial, because we all know that we don't really. But it's easier to believe that we do. And I still do. I still have a diary. I've got dates in it and times in it. And I really believe those things will happen then and something won't get in the way. And yet we all know how often we have to just change things in our diaries. Yeah. So this suffering, I think, is something that we can get alongside and help people to explore and unpick and look at what it is that's causing their distress, and help them to find ways to process it, to acknowledge it, to unpick it, to find ways to live alongside it so that it doesn't take away all the joy as well. So that people reach this place of knowing that a thing that they wish wasn't happening is happening, and also being able to be present in this moment to the good things that are happening in this moment. And now I'm going to sound like a mindfulness guru, but it turns out that mindfulness is a really, really useful thing when we feel overwhelmed by events. What we're feeling overwhelmed by is not this moment. It's what if it still feels like this in the next moment, and the next moment, and the next moment. So it's a future thing. And mindfulness brings us back into the now, because actually right now, I'm okay this second, and this second, and this second, this moment, and this moment, and this moment. So one of the things that we have found in cognitive behaviour therapy is that helping people to learn to be mindful, helping people to notice when they're able to report, oh yeah, I had a really good morning one day last week. Okay, tell me about that morning. And then they will be able to describe in great detail all of the wonderful things that happened. They had a phone call from their grandchildren in Australia, because it was the night time in Australia and they were having a birthday party. and they were able to read them a bedtime story before they went to bed. And actually that day there was a really fantastic sunrise that morning, because I woke early because I was uncomfortable, but when I opened the curtain, the sky was beautiful, and you just suddenly think, okay, this person's had a good morning. And what's happened is they hadn't realised it at the time, but they've had a mindful morning. Woken by pain, but what did I notice? Was it my pain? No, actually it was the sunrise. And then it was getting breakfast in time for the phone call to Australia, because I was looking forward to that and the joy of my grandchildren. And I hope that I'll be alive for the next time they come and visit. And once you help them to see that there's still joy, okay, what was it that helped that to be a joyous morning? You know, people aren't silly. People are intelligent. They can say, oh yeah, actually what happened was I focused on all of the things that were great that morning. There were terrible things as well. My back was really sore and I was constipated and I trod on the cat. But actually, what I did was focused on what was good and moved my focus away from the difficult things. And that sense of control that we have is the same illusion, that we focus on what we can do and what we can predict and what we think we can control. And we look away from the evidence that says a lot of the time we really don't have any control at all. And that illusion that we choose to live in also helps us to live comfortably and hopefully.
Yeah, it's true actually. I think mindfulness is a very important technique on so many levels, I think, isn't it? Especially in a situation like that, when sometimes you are in pain and you need to find a way to just sort of live in the moment, which is always quite tricky. And so it's been known to help, obviously, in lots of chronic conditions and things like that. So absolutely. I think that's such a sensible answer as well, and I totally understand it as well. Because you're right, we're not having a sensible debate about this at all. It is very much to a shouting match that's happening. So I really appreciate it. I think that it's very true. We do need to hear about the reality of just dying in itself, and I think probably this is missing most of it. So I really appreciate that. So thank you, Catherine, so much for speaking to me about this incredibly important subject, and also, even giving me your viewpoints, as you have, on potentially the problems with not having a good debate about assisted dying. So really appreciate it.
Well, thank you very, very much for inviting me to chat and for sharing your questions and ideas. I'm delighted that you've enjoyed the book, but it's been really lovely to just throw some ideas around with you. I've really enjoyed it. Thank you.